Bismillahirrahmanirrahim. I'm Dr. Muzamil Iftikhar from Medical Unit 5. Today we will discuss a very important topic. I will start with a clinical case just to have an idea and a better understanding what we will discuss today. So we will go for the clinical case. The patient Mr. Ikram, 31 years old of age, presented in ER with complaint of sudden generalized headache, palpitations, and profuse sweating. His BP is 190 by 100 millimeter of mercury, pulse is 105 per minute, regular, remaining examinations unremarkable. He is not taking any medications or drugs. His sugar level is 130 milligram per deciliter. He had past history of similar attack 6 months back, for which he was prescribed some medications, which he stopped due to recurrent headache. So we have three questions in our mind. What is differential diagnosis? What is most likely diagnosis? How will you further proceed to evaluate? So keeping in mind this kind of scenario, what differentials will come into our mind? So I have enlisted these differentials in the next slide. So it is essential through hypertension, pheochromocytoma, anxiety attacks, use of cocaine or amphetamines, mastocytosis or carcinoid syndrome. Usually in this case, lacking of hypertension, the patient is not hypertensive, usually with the carcinoid. Then migraine, headache, intracranial lesions, and many of the drugs like monoamine oxidase inhibitors, nasal decongestants, and symptomatics can have a similar presentation. Then today we will discuss pheochromocytoma. So talking about pheochromocytoma and paragangliomas are catecholamine producing tumors derived from the sympathetic or parasympathetic nervous system. So you see it is the neural crest cell which then gives to produce neuroblasts, sympathoadrenal progenitor cells that produce neuroblastoma. These neuroblasts can give rise to chromaffin cells and the sympathetic ganglion cells, from where intraadrenal, extraadrenal, and ganglion neuromas can evolve. And these chromaffin cells are also involved in the pheochromocytoma, which could be intraadrenal or could be extraadrenal. So we will discuss about the intraadrenal pheochromocytoma today. So if we enlist the catecholamine producing tumors, the number one is the pheochromocytoma, then the paragangliomas. Usually these are the extraadrenal pheochromocytomas, then ganglioneuromas, and then neuroblastomas. And quidectomas and the glomus jugular tumors, which usually occurs in the intercranial branch of the 9th and 10th cranial nerves and behave like paragangliomas biochemically. Pheochromocytomas are 2 to 8 of 1 million persons per year. 0.1% of hypertensive patients harbor a pheochromocytoma. So, for simplicity, rule of 10 has been used to describe the mean age at diagnosis about 40 years, and the 10% are extrarenal, 10% occur in children, 10% familial. In some cases, somehow it's closer to 20% as well. So 20% is bilateral, multiple, 10% reoccur, 10% malignant, 10% discovered incidentally. So you can remember easily just by a rule of 10 formula. There is no difference in prevalence in male or female. Usually third and fifth decade of life, patients develop the symptoms. When we will investigate for pheochromocytoma, if there are signs of symptoms of pheochromocytoma is there, if there is severe hypertension or there is hypertensive crisis, or refractory hypertension, if the patient is taking more than 3 drugs and no response, and if the age is too low, below 20 years, or it is above 50 years, There are adrenal lesions if they are found incidentally on imaging. They are also been called as incidentalomas. Talking about signs and symptoms, we have 5 P's. First of all, hypertension. This is a pressure symptom. There are about the 90% of the patients having this. And then the pain, headache is 80% of the patients having this. Then perspiration 71%, palpitation 64%, and then pallor and paroxysm. Paroxysm can be added as the sixth tool. This formula is to remember the symptoms easily. The classical triad. The classical symptoms are the pain, that is headache, the perspiration, and the palpitation. If these are three are present, then there is virtually the diagnosis of pheochromocytoma can be made. Paroxysm spells. It could be 10 to 60 minutes duration. Frequency it could be daily, it could be on the monthly or daily to monthly. Can be spontaneous, can have some precipitating factors. For example, diagnostic procedures. If a patient is given intra-arterial contrast, IV is okay. And then if the patient is having some drugs like opiates, unopposed beta blockage, anesthetic induction, histamine, ACTH, glucagon, and metoclopramide, commonly used in the wards. And strenuous exercise, movement that increase intra-abdominal pressures like lifting, straining, can also precipitate the attack. Then micturition. Micturition, if there is a bladder paragangliomas, it will also precipitate the paroxysm or the attack. Then comes the hypotension. So hypotension, orthostatic usually occurs mainly in many patients. So many of the mechanisms have been postulated. There may be extracellular fluid volume contraction. There could be loss of posture reflexes due to the prolonged catecholamine stimulation. There could be tumor release of adenomedullin, which is a vasodilatory neuropeptide, leading to the vasodilatation and the hypotension. Talking about other signs and symptoms, patient may have nausea, vomiting, abdominal pain, severe constipation that can lead to megacolon. There may be chest pain because of anxiety as well. The patient might be having angina, myocardial infarction with normal coronaries. It is because the catecholamines induce increased cardiac contractility, which lead to increased myocardial oxygen consumption, oxygen demand, and also there may be coronary vasospasm at the same time. Then patient might be having features of chronic heart failure because of hypertension. There could be hypertrophic cardiomyopathy, there could be diastolic dysfunction, catecholamines induced dilated cardiomyopathy or systolic dysfunction. There could be cardiac arrhythmias, patient may present with cardiac dysrhythmias or conduction defects. And patient can have features of hypercalcemia at the presentation if it is associated with MEN2 hyperparathyroidism, or there is a release of parathyroid hormone releasing peptide secretions from the pheochromocytoma. Then there is the familial pheochromocytoma. It could be MEN2A. In 50%, pheochromocytoma are present in MEN2A. They are usually bilateral and they are associated with medullary thyroid carcinoma or hyperparathyroidism. Then MEN2B. Then von Hippel-Lindau disease, in which there is the retinoblastoma, there is cerebellar hemangiomas, there are nephromas, renal pancreatic cysts. Then comes the neurofibromatosis 1, in which there is the cephalosporins, neurofibromas, and optic gliomas. Then there is the term familial paragangliomas, as we discussed in the previous slides, and there could be familial pheochromocytomas and islet cell tumors. There are many others like tuberous sclerosis, Weber's, ataxia, telangiectasia, Carney's triad, which includes pheochromocytoma, gastric leiomyoma, and pulmonary chondromas at the same time. How we will diagnose pheochromocytoma? Definitely, firstly we will go for biochemical testing, then we will go for localization of the disease. So 24-hour urinary collection is important. You will go for creatinine, catecholamines, metanephrines, VMA, and plus minus dopamine levels. Plasma metanephrine collections can also be done. Catecholamines and metanephrines can be measured by using different methods in a clinical context, suspicious for pheochromocytoma when values are increasing 3 times the upper limit of normal. A pheochromocytoma is highly likely regardless of the assay being used to diagnose. Then how we will localize? We have a CT scan abdomen, we have a MRI abdomen, then we have MIBG scan. Each is having almost 90 to 100% sensitivity, but the MIBG scan is more specific than the CT and MRI. The MRI is more specific, more sensitive than CT scan of abdomen. Here you see a left-sided pheochromocytoma, CT abdomen showing an arrow at the lesion site. Again you will see MRI, better localization of the lesion. You see the arrowheads at the site of lesion. Here comes the MIBG scan viewing a left-sided pheochromocytoma. How we will manage? Prior to 1951, mortality was very high while excising the pheochromocytoma. It is almost reaching to 50%. Maybe due to hypertensive crisis, many will die of arrhythmias, many of MI, stroke, or there may be hypotension, intensive shock. Currently, mortality has been reduced by 0 to 2.7% while excising the pheochromocytoma because of perioperative preparations, alpha blockage, and new anesthetic techniques, anesthetic agents, intraoperative monitoring like arterial line, ECG, CVP, swan gas catheterization, etc. So talking about the perioperative preparation regimes, there are many regimes available. We can combine alpha with beta blocker, we can have a metyrosine, we can have a calcium channel blocker. Talking about the combination of alpha and beta blocker, there is available of phenoxybenzamine, there is available selective alpha 1 blocker which is called prazosin or propranolol. So how we will start alpha blockage followed by beta blockage? It should be started 10 to 14 days before surgery so that you may have a sufficient time for extra cellular fluid volume re-expansion. First of all, we will have few words about the phenoxybenzamine, which is alpha blocker. It's not present over the counter. It's a drug of choice. It binds with alpha receptors. We will start with 10 milligram twice a day. Then every second day you can increase with the 10 to 20 milligram. And our target is to control blood pressure and no more paroxysm. And the maintenance dose of 40 to 80 milligram per day can be given maximum. Some patients may need more than 200 milligram per day. You can load patient with salt, with fluids, normal saline, or having sodium chloride 600 milligram OD or 3 times a day as tolerated by the patient. The phenoxybenzamine have a few side effects, the orthostasis with the dosage required to normalization and seated blood pressure, reflex tachycardia. You may have a perioperative hypotension, shock, unlikely to respond to pressure agents as other shocks can. Selective alpha blockers are available as prazosin, trazosine, and doxazosine. They are not routinely used as incompletely block the alpha receptors, used more for long-term treatment if the pheochromocytoma is not operable. And then we usually combine a beta blocker to control reflex tachycardia and prophylaxis against arrhythmias during surgery. Start only after effective alpha blockage because it may precipitate hypertension. If suspected chronic heart failure or dilated cardiomyopathy, start low dose of beta blocker. Propranolol, most studied drug in the pheochromocytoma perioperative preparations. Usually we start it with 10 milligram per oral twice a day, and then we usually increase it to control the heart rate according to the heart rate. Before surgery at the morning of the surgery, we usually give an IV phentolamine to control blood pressure. Short-acting, non-selective alpha blocker, we give a test dose of 1 milligram, then 2 milligram, then 5 milligram IV in 1 to 2 hours, or as for requirement, or as continuous infusion. For example, 100 milligram in 500 cc dextrose water titrated to control the blood pressure. We can give IV nitroprusside as well as usually not available in Pakistan. Then we can have a perioperative arrhythmia control. If the patient develops arrhythmias, you can give IV ismolol if there is no cardiac conduction or structural defects. Then you can have IV crystalloids or colloids to treat perioperative hypotension if the patients come across hypotension instead of hypertension. If pheochromocytoma is not resectable, you have to go for long-term therapy, and for that alpha blockage is been preferred. The selective alpha 1 blockers like prazosin, trazosine, doxazosine, these are the first line because they have the less side effects. Phenoxybenzamine causes a more complete alpha blockage, but it is the second line drug. Then we combine it with beta blocker, calcium channel blocker, ACE inhibitors, and there are some nuclear medicines also available to treat this malignancy. So talking about finally, pheochromocytomas are rare cause of secondary hypertension. Majorities are benign in nature, must be considered in young hypertensive individuals. Persistent hypertension may be present in 50% of patients. Surgical section leads to the cure of hypertension in majority of the patients. So thank you very much. We may have question answer session if we have a interactive discussion. Thank you very much.